To day 3, implementing strategies using the exercise prescription. Remember, just like we talked about with the diet prescription, we want this science to actually make it to the patient and create outcomes, because otherwise this is just a bunch of things you know and not things that you know how to put into practice. So we've listened, we know that's really what you're up to, so let's get started. So I'm going to be speaking about just some general aspects of exercise prescription implementation and some ideas that we use in our practice. And then, of course, share the brilliant ideas with some of the other colleagues who also are figuring out ways to make this work in their practice. So the first thing I want to share with you is when you're approaching a patient with an exercise prescription, assuming the patient's interested, you might want to ascertain first, how is this person motivated? Because it always makes sense to kind of ride their motivation wave than it is to come from a standpoint of, this is what I want from you, and this is why I think you need to do it. So it's less about a doctor's orders or a provider's recommendation. You really want to partner with our patient therapeutically, and that means understanding what's their motivation. So for most people, there are 2 ways that we can reinforce the outcome of a positive implementation of exercise. Number 1, we want to optimize those factors that relate to one-on-one communication with our patient. And then number 2, optimize the environment in our practice for success. Okay, so we're going to go over these things in detail now. So the first thing that I just want to put out there is that you want to make sure that this patient has a reason to want to exercise. Just giving them some prescription and assuming that they're going to want to do it doesn't always work, as you know. So, if Joan Rivers was your patient in the past, this might have been her reason for not wanting to exercise, and you got to be able to roll with it. Let's talk about how we can do that. So the main thing I want to suggest is, and this works not only with patients, it works with spouses and children. It is wise to persuade people to do things and make them think it was their own idea. So Nelson Mandela, with much bigger goals in mind, used the same principle. So I want you to think about, who are you working with? Who are you partnering with? And these are some common functional medicine personas that you may come across, especially if you're in more of a private practice, whether it's cash or membership type of practice. You might see this persona of people. Is this all personas? Absolutely not. This is from my private practice experience, so this is what I'm able to share here. So what you see, and I invite you to look at this in the future and just kind of get a sense of, who do you serve? You might be serving unwell Ellen. She is kind of the chronically ill, high touch, needs a lot of hand holding. Or maybe you have a practice where you have a whole practice full of lifestyle lens, like the people who read all the fitness magazines or doing everything following the leaders. And the way you engage with each one of these personas is based on what their goal is for exercise. So you can imagine that unwell Ellen may have a different set of goals and challenges or limitations than lifestyle Len. Okay, so make sure you know who you are working with. And if you're not sure, have a conversation with them to find out. Now, let's just say you've gotten through that step and now you're in the actual conversation of, hey, let's figure out how to get this exercise thing creating benefits in your life. Well, as you're having the conversation, there are aspects of motivational interviewing that you might learn to use. So rolling with resistance, for example. Sometimes people are just, nope, I don't want to exercise. So in this example, you might say, okay, well, if you don't want to exercise at a gym, what other options have you heard of that you might want to consider, right? Like, let's say that that's how you opened it up. So remember that there's always a way to roll with the resistance, and it's really focused on acknowledging the patient's input, That's what you're saying. Okay, fine. You don't want to work at a gym. I get that. And express empathy. I mean, I get that you've tried to work at a gym and the machines tend to injure you. You're too petite. This is one of my problems at gyms. Like the settings don't work for me and my height. So, yeah, I get that, Shilpa. That's got to be frustrating. So, you feel because the equipment is not made for a person your size that it doesn't work for you. So notice that you can empathize without judging and then roll with resistance and then make sure they understand that you acknowledge what their input is about the situation, okay? These things are probably common sense to you. Having said that, many of us may not employ these to the fullest potential we can to really motivate our patients to implement exercise. Now, really important, obvious, not to argue with your patient, right? Because all that's going to create for most people, most toddlers, most spouses is more resistance. So if they say, hey, I don't want to exercise right now, well, then you can say, would you be willing to talk about exercising as a goal in the future? And if they say, yeah, I just need to make it through December. Okay, great. Let's have you follow up with me in January. Does that work for you? So again, avoiding arguing, expressing empathy, like I get it. This is holiday time is crazy here, and rolling with resistance. What's next? And develop discrepancy. So sometimes people say things that kind of conflict, right? So they might say, yeah, I want to exercise because I don't want to take a statin medication, but I don't have time to exercise. So this is where you help them understand, like you recognize that exercise is one of the key ways to reduce your need for a statin medication. And you get that, if we leave this cholesterol the way it is, it's going to cause more risks for you. But at the same time, time is a factor. So, what are other ideas that we can come up with? Okay. Remember that you don't have to solve everything for someone. You could probably just put things out, like develop discrepancy for the patient and then let the patient generate solutions. It actually does work. So also support self-efficacy. This means that we are not the ones who are going to change the behavior. The patient is the one who has to change the behavior, and their understanding of their capacity to change their behavior is essential. So whatever you can do to point out the positives, acknowledge whatever they've done, even if it's like, hey, it's wonderful that you bought sneakers. Now, I get that you didn't do anything that we talked about. Life happens. I just want to acknowledge you for getting the sneakers because that makes it that much easier to start the plan now, right? So support self-efficacy whenever possible. Now, there might be other kind of more tangible obstacles that keep someone from wanting to implement exercise. Many times it's either on a mental plane or it could be on a physical plane. So here's some solutions that I've listed for some of the common mental obstacles that I've seen. So there's definitely people who don't want to be out in public because of some body image concerns that they have. So, many times they can go to maybe a special kind of gym if they want to go to a gym, or perhaps they can do at-home videos or a personal trainer. Sometimes it gets boring. So I get, when I know I'm exercising, I just moan and groan about it. But if I'm having fun dancing, like I'm doing a Latin workout right now, I'm having fun. And oh, by the way, I'm exercising as well. Change it up throughout the week. These are things you could do. Lack of knowledge, or let's say they just don't have confidence about how to do it correctly, or how to do it in the right amount of time. That's when you might want to bring in a health coach or personal trainer. And with physical obstacles, which may be related to, this person hasn't been exercising for a long time, and assuming that you've cleared them to be able to initiate an exercise plan, maybe there are ways that you can just say, okay, listen, I just want you to walk at a low intensity to start with. And, over the next month, I'd like you to build up to 5,000 steps a day, 3 days a week or 4 days a week, or whatever you decide and does that work with you, Sue? That might be one way to work on physical limitations or perceived physical limitations. And then there may be people who have real time constraints. So the two ways that I tend to handle that is number one, I optimize NEAT. If you remember, we talked about non-exercise activity thermogenesis. So take the stairs, park farther away, walk during your lunch break, have walking appointments, walking meetings. Figure out ways that when you're watching TV in the evening that you could be pumping some weights, some free weights right there in your bedroom or in your living room. Or maybe if they are more avid exercisers and they're open to taking on some HIIT training, that might be a way to get some concentrated cardio and strength training signals in the body. So now the next thing I want to talk about is the different scenarios that we may have in terms of our office structures that support implementing exercise. So on the far left is perhaps a common scenario, like you don't have a dedicated person in-house that is going to help people implement the exercise prescription. Like maybe it's you, okay? So if you are the provider and the health coach and the personal trainer, then what I want you to consider is use resources. It's really important that you recognize your boundaries in terms of not being able to be everything to everyone, but to use your resources effectively, because we can't create boundaries that are so tight that you're not creating the type of office that you want, meaning one that incorporates exercise prescriptions. So here's some tools that I use that I'm going to share out. So we're going to talk about an office workout, an exercise grid, and then also how I will work with the local community personal trainers and gyms to refer out. And I actually have trained them to look at my exercise prescription as a guideline. Even though I'm not partnered with them in a legal way, they use these prescriptions as a way of communicating with what my goals are. And then also, especially in certain times like we're having right now, I refer to online resources as well. So this office workout prescription was created by my team, and I'll show it to you here in a second, but we just literally hand out this resource to the patient. We encourage them to find a buddy in their office or at home because it generally tends to be more fun. In fact, there's data to suggest that when you do exercise in a social format, i.e. team sports seem to create more benefit than doing an individual sport or like being at the gym with your, AirPods on, centered only on yourself. So there seems to be this association where having a social element to your exercise regimen seems to up the benefits. Absolutely set up reminders on your phone when you're at the office to do these hourly 5-minute exercises. And then I also have an online link, which is functionalfix.org, that our personal trainer and health coach demonstrates proper form and modifications for these office workouts. And then, of course, once you give any type of resource, whether it's this, office workout prescription or any other resource, determine with the patient, hey, what do we want to do about this? I don't want to just give out this and say, hope it works. Like, do you want to have an accountability? Like, hey, can you come back to see me in a month? Let's see where you are with it. Or, hey, can you consider taking it to this next level after a month if you feel good, and then come back to see me in 2 months? Or, hey, once you're done with this, why don't we in 2 months recheck your lipids and see if you made a bump in your LDL particle number so that we can lower the dose of your statin or get you off the statin. So I don't recommend just doing an exercise prescription and leaving it open-ended in terms of follow-up. Make it be like any other prescription. If you were to put someone on a statin, you would follow up with them. So just like that, you would follow up with someone that you prescribe an exercise prescription. So this is that office workout that I mentioned. Again, it's really practical. It's something that can be done whether you work in an office, a home office, or you don't work at an office, but you work in the house. So it's in your IFM toolkit. And what it literally has is a Monday through Friday, 8 to 5, like grid of what do you do 8 to 9 on Monday? What do you do 9 to 10 on Tuesday? So it kind of diversifies exercises. And it makes it so all your muscle groups are being incorporated using the stuff you have in an office or a typical home. So it's beautiful for the I don't know what to do people, okay? And it's a great start for sedentary people. Then you can also consider any technology that is of interest to you. Here are some that our health coach and personal trainer has suggested you consider based on what the patient's goals are. Maybe they're trying to run a 5K, then find an app that might work for them there. Or maybe they want to incorporate yoga in order to work on their mind-body access or flexibility. You can personalize it to the type of workout if they're interested in HIIT or yoga or Pilates. Again, find technologies that you enjoy, really check them out yourself, or you can make a little cheat sheet that can be given out or put as a template in your note. Now, here's something really important that I want you to consider if you're not doing it already. It's called delegation. Now, this is something that I used in my insurance-based practice. When I first started my practice back in 2004, I was your typical board-certified family physician out to make a difference, knew nothing about functional medicine, integrative medicine at the time. And as I started learning more, I realized I can't be the person to do all this education. And so what I started to do was bring in health coaches onto my team, and I delegated my education to them and build insurance as though it was me doing the education. Now, this is done in healthcare all over the place. Respiratory therapists, many people will do delegated work from the healthcare provider. So it's just a transfer of responsibility for the performance of patient care. Now, remember that it's still done under the responsibility of the provider. And I want you to consider that different states, different insurance contracts may have little nuances on how they would want you to do delegation. But the way that I did it, knowing that things change and I can't keep up with them, was I wanted it to meet some minimal requirements, okay? So here's how we did it. So let's say the patient saw me, and then I say, listen, I want you to do a exercise prescription with our health coach. Well, then I would write up the exercise prescription, and then when the patient went to check out, they would create an appointment with the health coach, and that appointment would be 30 to 45 minutes based on whatever I put in checkout. But then during that same slot, they put on my schedule a 5 to 10 minute pop-in. So that's where I met the face-to-face requirement for me. I trained our health coach to be able to basically do my whole visit. And then when I would come in, she would literally check out, like, Susie's doing great on exercise. Her blood pressure is dropping a little bit on her blood pressure log. Do you want to adjust her medications? I would, say whatever I needed to say, maybe listen to heart, lungs. She would document that, done. That's how we delegated. But she did a majority of the education and the history generation. I came in for the parts that only I should be doing, which is the physical exam and the recommendations. Now, she sometimes already knew what my recommendations were going to be. So she would say, okay, this is what I'm thinking to do. And then I would approve because it is my visit under insurance. So this is the step-by-step process here if you wanted to take a look at it, again, in detail. Again, the main point here is you are delegating the educational process related to the exercise prescription. You can use it for the diet prescription. You can use it for anything that tends to be educational and formatted. And I personally would make sure I had a face-to-face encounter with the patient to meet my legal requirement for insurance in order to bill it as a 99213 or a 99214 based on the documentation complexity. So what we do with our health coach is we also want to have her or him do other cross-trained roles in our office because we're a small little practice. So, our health coach, because she's so intimately involved with our patients, really knows how to assess if a new patient who's interested would be a good candidate for our services. She's great at doing the technology that we do with some of our new patients, whether it's a BIA or if we prescribe heart math. So she's great with technology. She's great with education around nutrition, exercise, whatever you can train your health coach to do, then you can create a way to delegate for her to do it, whether it's through insurance or cash, right? Now, last but certainly not least, it is so important to know, and you know this if you have children or, if you have a family member, which I know you do, that what you say and what you do are two different things. So there are studies that show an association that if a provider is exercising, is implementing a journey of improving their exercise and diet, it seems to show up more in their recommendations. And when a provider talks about it authentically during a motivational interviewing process with a patient, it's obvious to the patient that it's important to the provider because they're not just talking the talk, they're walking the walk. And that, I would say, is really important for all of us. I mean, we are patients as well, to consider that one of the best ways to start an exercise prescription program in your office is to do one for yourself, walk yourself through it, and see the little bumps and, chutes and ladders, if you will, aspect of the journey, so you can speak authentically to it and maybe start that office workout challenge in your own office. And I would tell you, we did that in our office. And what we noticed was people would be coming in and there would be some people doing desk push-ups. And they were like, what are you doing? We're like, we're just getting our desk push-ups in. Just hold on just a second. I'll be right with you. Or somebody comes in and we're doing squats and having a conversation about a patient. I mean, it sounds humorous, but they know that we mean business when we say, let's do an exercise prescription. So remember that for patients, knowing things is lovely, but it doesn't change outcomes. Doing things changes outcomes, and your behavior matters. So I hope you have found this portion of our day-to-day useful. I'm surely available to you to answer questions during the online forum. I'm excited to see what you guys create in your offices, knowing that exercise is such an underutilized tool in our armamentarium for optimizing our patients' lives. Okay, so that was enough about me and my office and what I have to say. I'm excited to invite Yusuf and Michael onto this panel and kind of further the conversation and learn from what they found to be useful ways of implementing the exercise prescription in their unique office settings. Welcome back. So we've got the three amigos here again. We are missing one amigo. She will be here soon. So we are going to talk about our strategies for implementing exercise in our practices. So Yusuf, how about we start with you? Can you say like a 30-second blurb about your practice and then how you implement exercise so people can get context first and then understand your model?
Okay, 30-second, just the practice, like, and then the rest of the time, just how I...
Then you tell about how you incorporate exercise. Yes, please.
Awesome. So we currently have 6 providers. There's 2 PAs, there's 2 NPs, and 2 physicians. I'm an MD, and there's a DO. We have 4 health educators. We also have, we're in an insurance-based hybrid. So we do mainly insurance-based, but the things that insurance doesn't cover, we do offer them. And, or we offer some things that insurance doesn't cover. We also have,
As cash.
As cash, but okay. I'm talking about supplements and maybe neurofeedback and that type of thing. Most of this stuff, insurance is going to cover. Okay. And the health educators, there's 2 that are behavioral health specialists. One is an exercise physiologist. One is a health coach that just grew up in a family of CrossFitters. So he grew up doing CrossFit. We have him walk around the office every once in a while just to kind of, he does it so we don't have to. I mean, he's, no matter what he wears, he looks pretty, what's the proper term?
He looks like he walks the walk.
He looks like he walks the walk.
Okay.
A little bit too much.
How about you tell us how you incorporate exercise?
So how do we incorporate exercise? It It can start off as simple as asking them about their movement, seeing what it is that they enjoy doing when it comes to exercise, and starting something slow, just maybe 5 to 10 minutes. Make a commitment, say, okay, well, can you walk? If you like walking, could you walk for 10 minutes a day? Like, could you? And make sure that you track it and come back in 2 to 3 weeks, and we'll review that. And then from there, if it gets a little bit, if I mean, sometimes the providers will give them a cardiovascular prescription. We'll give them a resistance training, maybe a stretch prescription. But the cool thing is that we can reiterate it by saying, and I want you to see one of our health coaches, one of our educators in 2 to 3 weeks, so that they can go over maybe a stretch program or go over a resistance program, or figure out what exercise would be best for you. We'll use some of the tools we have. We will do we have a bioimpedance test, so we'll check percent fat, percent water, muscle, connective tissue. That'll look at the phase angle. The phase angle is how strong the cells repel electricity, and the higher their phase angle, the better they would do with chronic diseases and with cancer. So we encourage improving this phase angle, improving the hydration, and really showing them the difference between having weight and having fat. There's a big difference between.
I'm going to interrupt you. I'm sorry. I don't want to go into the science. We're going to focus on implementation, because you're such a smarty pants when it comes to science. But what I'm hearing you say is that operationally, you incorporate a BIA, you incorporate the exercise physiologist. Do you use delegation to get that paid for? So can you just tell our listeners how that works for you in an insurance-based model, how you delegate to the health coaches?
Right. So the two options. One option is we bill for chronic care management, and with chronic care management, what happens is if you have two chronic diseases and you're Medicare or Medicare managed care, you can have a coach call you on the phone and you bill. It's around $45 for every 20 minutes they spend with their care. And the second way is that we have an office visit, and the office visit will be limited time with the provider. So any one of the providers available will go see the patient, maybe take 5 minutes, and then the coach can sit and take up to an hour and half an hour to an hour going over things with them.
So perfect. So Yusuf, you talked about two different ways to bill and code it. One through the health coach themselves with the chronic care code. And then the second one was what I call delegation, which is the provider, who's the insurance billable provider, can have a 5-minute face-to-face contact. You have documentation complexity that the health coach fills out in your EMR and your visit note, but you made the face-to-face contact as the MDDOPANP, the billable provider. And then the rest of the time, the coach is doing the education, but you're still billing a 99213 or a 99214 based on the complexity of their condition and the documentation, obviously. So awesome. So you are leveraging group in order to get exercise group inside your practice, because you have some people who know how to deliver exercise as medicine, and you get them to partner with you so that you are not the one who's doing that. So wonderful segue. So, and that's in the insurance-based model. I just want to call that out. That just becomes immensely easier if you want to do it in cash, right? You just have a fee. Now, Michael, Michael, just for the sake of time, I want to make sure we get more time in. Can you give us a 30-second synopsis of your practice setup, and then how do you leverage group outside of your practice?
Very good. We have an insurance-based practice with 3 MDs or DOs, nurse practitioner, PA, additionally, and then 2 nutritionists. Listening to what Yusuf said, almost everything you do, except we don't have a exercise physiologist, and we don't have one of our nutrition. Well, we have a couple people that really walk the walk, and so that's awesome. So what we do is we leverage aspects of our group medical business, and our nutritionists actually spend quite a bit of time actually showing active stretching, passive stretching, talking about using the BIA, same leverage points. is very important in our practice within our community, with a small college, with the Y, with other private physical therapists. Some of them we have a whole group that we refer to. So anybody who has arthritic disease over the age of 50, some chronic disease, we actually refer them very actively to either the physical therapist who has a whole program for people with autoimmune disease, post-MI, all that. We also have a very aggressive referral program for water aerobics and everything through the Y. So I would say that takes the pressure off the practice, feeling like they have to do everything. The only additional thing is some of our providers actually do walking meetings. So getting people up and moving is just key. Movement is key.
Love it. So Yusuf and Michael have shown you that in an insurance-based model, you can either leverage people inside your group and or outside your group based on whatever your practice is interested in taking on. So if you have someone with a specialized skill, absolutely consider having that stuff stay in-house and kind of having that be, if you will, a brand of your functional medicine platform. And if you feel like, I don't want to be everything to everyone because this is our niche and that's okay, then find allies on the outside that you can partner with that get to know how you do medicine. Because I can't agree with you more, Michael, and I'm sure Yusuf, you agree that when you refer out, I have my go-to people that are not going to, let's say that they're going to honor the functional medicine model. And I even say, when you go to see Dr. Reyna, tell him you're one of my patients. He'll know that you're different. And it's true. Like when they come from a functional medicine model and you create this relationship with outside referral sources, when they know that you actually are interested or you're the type of patient who's interested in diet, exercise, reversing and reducing your disease, they may have a different type of program they're willing to try on you because they see like, oh, everybody that Dr. Stone sends over like also takes fish oil and takes vitamin D in their recovery and they're more proactive. Because I think outsiders can have become resigned and cynical, and they kind of sometimes give up on people. And we don't want our patients to be lumped in with the majority. So creating these nice little allies on the outside for the things that you don't want to do or can't do, I think is an amazing tool with exercise, or it could be with nutrition, or it could be with stress management. I mean, it's the same thing with lifestyle. You just consider either doing it in-house or out. Now, you also brought up, Michael, did you want to say something?
Yes.
I was going to say, you want to talk about
this is tying in with your toothbrush analogy in one of your previous talks. And that is this. I challenge everybody on this call, think about a couple things that you do every day where you're kind of static. One of them is brushing your teeth. While you're brushing your teeth, think about one or two stretches or balance things that you can do to work on your balance while you're brushing your teeth. One of our nutritionists has this whole deal that she says, when you brush your teeth, put one hand on the counter and start practicing on how long you can balance on one foot, stretching or balance on one foot, alternating, and see if you can improve your balance while you're brushing your teeth. And so what are these static things that we often think are static that we do every day that we can begin to incorporate stretching, because stretching activates your parasympathetic nervous system. And that's something all of us in a stressful life could use a little more of.
Awesome. So I like the way you're kind of bringing in NEAT. Remember, I talked about NEAT, non-exercise activity thermogenesis, just incorporating it into your life. And I will have to say, when you incorporate it into your life, it's more top of mind, so that when you're sitting there with your patient and you're thinking, how can I encourage them? Well, I don't know. This is what I do. And it just comes off so much more authentic when you're walking the walk, if you will. And you don't have to be the bodybuilder physique to be relatable and approachable. I think people are really interested in real practitioners who are showing that they're on the journey. They're on Prochaska's, stages of change, wherever you are. And then talk about when you fell. I mean, don't try to make yourself out to be this perfect embodiment of said I was going to do this and here I am, winning the CrossFit of America challenge. I think people relate to me the most when I say I went to an Indian wedding and I stopped exercising for 3 months afterwards, because they've all been there, going to something that just throws them off for 3 months before they try it again. So Yusuf, you were going to say something.
Yeah, I think the more we gracefully age, the more we see how injuries can occur and how pain can create more pain, which makes people not exercise. And sometimes to patients, it's counterintuitive that moving around is going to make them feel better. Mm-hmm. So don't forget, if you are a chiropractor, well, you won't forget it, but don't forget chiropractic care. Don't forget massage therapy. Don't forget sending them to acupuncture. Don't forget these modalities to kind of keep them moving in the direction. Stretch, have them take a yoga class or a stretch class. And don't forget P90X3 because aging is for idiots, according to P90X3.
Okay, well, we are going to pretend you didn't hear that. And we are going to come back to the subject at hand. Here's another thing that people have asked us about implementation. When you find someone who is a pre-contemplator, which is like they are so not interested in exercise and they just think it's not possible, maybe because of pain or because of time or because of COVID or whatever their resistance is. The goal would be to use motivational interviewing and use the aspects of motivational interviewing to just not convince them to exercise, but just to understand what's their resistance, roll with it. Like, oh yeah, I can imagine you're working 2 jobs. I can see why it would be hard for you to even imagine bringing exercise into your life right now. And then, see if there's some discrimination you want to help them with, like, okay, but you're trying to get off of this blood pressure medication. And I love that you're committed to that. So what other things can you see, or is there any part of exercise or physical activity that you could consider that could keep you moving towards your goal of getting off this medicine? So helping people see, like, yeah, I get that you have this time limitation. So you acknowledge and you roll with their resistance, but then give them the discrimination to say, yeah, and you're here because you want to get healthy. And I just have to tell you, exercise is one of the big levers. So if you do nothing, you're going to keep getting what you're getting. So does anything else come to your mind as a solution? And I can't tell you how much it improves things when you have the patient be the person who comes up with the idea of what to do next versus feeling the burden of having to be the one who psychically knows what this patient's going to do. I don't know about you guys, but that gets to be exhausting trying to, for me, anticipate the right answer for the patient.
Yeah, it's convincing versus agreeing with.
Mm-hmm. Yeah, and there's an art to shutting up. I'm still learning it.
Yeah, I think that for patients that are using Fitbits or they already have their phone on and they track their steps, I think them being accountable for their steps, and even if it's a low number, even if they're doing 3,000 and pushing it to 4, just moving them. I don't even think it's a word, but since I met you, Shilpa, I keep saying ooch, and people look at me like I'm funny.
Ooch,
ooch. I don't think it's real though. I don't think it's, but fine. You get them to ooch in that direction. But I like that you mentioned the motivational interviewing piece. So here's the piece. So you're like, so scale of 1 to 10, 10 being the most motivated, 1 being the least. How motivated are you to exercise? A 3. Awesome. Why didn't you say a 1? And then why didn't you say a 1 is going to give you some positives to work with. Well, because I know I kind of need to do it. All right. Well, that being said, what kind of movement do you feel you would be the most inclined to do? And then that way you're not telling them to do anything. You kind of go back and forth and you're offering them just suggestions, kind of like a therapist, but you're picking the exercise out of them. And then I don't remember if you talked about it this time, but the SMART goals, make sure that it's specific. So, okay, you're going to exercise. Great. When? What days a week? What time are you planning on doing that? Get them to commit to specifics that you can kind of hold them to.
Yeah, measurable, right? Action oriented, right? That you can track. So one thing that I love that we're bringing up, and this doesn't apply just to exercise, but exercise just seems to be the one that people will sometimes completely believe in, but will resist. Yeah, like they're more likely to take on a diet sometimes than they are to take on exercise. So you can apply these principles to anything, like taking supplements, taking a shake, doing the diet, whatever happens to be their resistance point in a functional medicine treatment plan. You can use these things. One of the things that I've learned from the movie My Big Fat Greek Wedding is the head and neck philosophy is what I call it. So like when I counsel patients on parenting their toddlers, I always say, your toddler is trying to develop independence. So instead of telling them, what do you want to eat? You say, do you want to eat carrots or peas? And now the toddler's like, look at me, I'm the boss. I got to pick carrots or peas, but you were the neck. He thinks he's the head of the household, but you were the darn neck in that decision-making. So sometimes we have to consider that might help a patient. So just like Yusuf is saying, like, you ask, oh, there are 3, and then they say, well, what kept you from being 1? And they tell you, oh, because I know I need to do it. And then you can even ask, okay, so what's keeping you? Is it time? Is it pain? And then perhaps if they say time, you might have 2 go-to options. Like, hey, could you do a HIIT routine? I'll copy paste a few HIIT routine things on YouTube that you can look into and see if that's your style. Or if it's like, oh, well, then perhaps you can get a treadmill desk, or like you could copy paste ideas on, if time is their answer for resistance, these are your go-to suggestions. But they picked time. So they are in the control seat, if that makes sense, as opposed to you telling them, I think you should do this. Because when they pick it, you all know when you're married, when your spouse picks what's going to happen, even though you wanted it, when they pick it, it's more likely to occur. They're more excited about doing it. When you tell them to do it, it never works out as beautifully as them saying, I want to do it originally. And I see
Right.
Michael nodding because he's like, oh, is that what my wife's been doing to me?
Right.
It's easier to agree with than convince.
How do you feel about making me a sandwich scale of 1 to 10?
Okay.
It's
Here we
time
go.
to
Oh,
We are
0.
at
I
the top
see.
of the hour.
Sleeping on the couch.
Top of the hour, Yusuf.
Sleeping on the couch.
We're going to now move on. Actually, I can't imagine that we're going to actually let you speak again, Yusuf. No, I'm kidding. We have a lot of good things to say about venous insufficiency. So we're going to go on to tackling common cardiovascular conundrums. Yusuf is going to start us off with venous insufficiency. All right, hang tight while we do our little audio visual changeovers.